Cluster headache is one of the primary headache disorder. The headache is quite severe, unilateral, periorbital, and it usually peaks in the few minutes and lasts for half an hour or so. It's one of the very severe variety of the pain disorder. It is important to know that treatment of this disorder is slightly different from the migraine. Though some of the drugs are common, but some of the drugs which are effective in migraine may not be effective in the cluster headache. Treatment of the cluster headache involves three different strategies. First is the abortive, which refers to the treatment of an individual attack. Transitional treatment is given at the onset of a cluster period with intention of decreasing the frequency of the attacks. Simultaneously with transitional therapy, preventive treatment are used for the anticipated duration of the cluster period to reduce the frequency, duration and severity of individual cluster attacks. Now, point for important is that for the abortive therapy, we can use the zolmitriptan and the other variety of the triptans, and they have shown efficacy. Oxygen is also an established effective acute treatment option for the cluster headache. It is delivered at the rate of 6 to 15 liter per minute. Many of these patients, they become addicted to the opioids, because some of the clinicians, they use them without knowing that this is cluster headache and may respond to the triptans, the abortive therapy. Both zolmitriptan and sumatriptan are available in intranasal formulation and can also be used IV. Now, we can use subcutaneous sumatriptan also. Also, the oral randomized placebo-controlled trial of octreotide has shown the efficacy. Overall, the treatment appears to be relatively well tolerated. Another important intervention is the sphenopalatine ganglion has long been a therapeutic target in the treatment of cluster headache. Blockade with the suprazygomatic alcohol injections have relieved this pain in 85% of the patients in one study. Using endoscopic technique, 20 patients with the refractory cluster headache were treated with the injection of the corticosteroids and local anesthetics directed towards the sphenopalatine ganglion. The option for the oral transitional therapy are rather limited, essentially restricted to the corticosteroids, being used in the 1 milligram per kg body weight for a minimum dose of 40 mg. The benefit of the oral steroid is that their administration is not dependent on operator or medical setting, and is more convenient for the patient. Oral triptan has been reported a potential option for the transitional treatment in the cluster headache also. Now, parenteral corticosteroids may also be benefit for some patients who got severe headache. Then we have got suboccipital steroid injections, which has got evidence, and it is currently the only preventive strategy to have a level A recommendation from the AHS guidelines, although it is primarily used as a transitional strategy. Now, a recent observation has revealed that triamcinolone and bupivacaine injection can lead to a longer pain-free periods in the episodic headaches. Now, oral agents which are used for the prevention, of course, the most common is the verapamil, and this is the most common drug which is used in the cluster headache for the treatment for the prevention of the attacks. The drug is available in the tablet of the 40 mg and 120 mg, and we can use 40 mg TDS or 120 mg sustained release preparation daily. Now, lithium also has got a level C recommendation, and this has shown be effective in the prevention. Melatonin also has shown some efficacy in the prevention. Now, suboccipital steroid injection, only preventive measure which has given the level A recommendation. Then some of the devices like the non-invasive vagus nerve stimulation has been studied in the prevention of the cluster headache. Now, emerging therapies are the monoclonal antibodies that target the CGRP ligands, which have been effective for the prevention of episodic and the chronic migraine, are currently being also studied in the episodic cluster headache. To be noted is the frimazumab and the galcanezumab is being studied in the episodic and the chronic cluster headache. Now coming to the question of which is being there today on the Indian Academy of Neurology site, that which treatment has not been found to be effective for the cluster headache. Of course, we know now that the lithium has shown efficacy. Galcanezumab, one of the monoclonal antibodies, is being studied and has shown some efficacy, and suboccipital corticosteroid injection has shown the level A recommendation. Lithium has got level C recommendation, and galcanezumab is being studied and shown efficacy. Now, important to note what might have a general impression that sodium valproate may be effective. It is not effective in the migraine. It is not effective in the cluster headache. However, sodium valproate is effective in migraine. So this point has to be noted that in the cluster headache, sodium valproate has got no role in the prevention. Thank you.